thought I should probably say that that's what I do all my whole life, because that's what ONG is. I'm really sorry I'm late. It's essentially how I introduce myself to you. So, why do ONG, you ask yourself? Well, I thought I'd talk about my day, because that's actually the reason I do ONG. I really like it. It's a great specialty. I'm glad I landed in it. So, this morning, or no, last week, I got up, got in my car and drove to the Mercy and spent the whole day in the operating theatre, and I took out someone's uterus and I took out endometriosis, and they were extremely challenging operations. They were all laparoscopic, some hysteroscopic procedures. And at the end of the day, I was exhausted and my arms hurt, and I sat in the car and went home. And the next day I went to the hospital, and I sat down and talked to some people about heavy bleeding and pain, and then all of a sudden I met somebody who said to me she'd been sexually abused. So we went down that path, and we spent a lot of time talking about that. And that's often what you see when people come in with pelvic pain, because that's a big factor of it. So, and then I took a plane and went to Sydney and did a robotics workshop. And then, so now I was thinking about how to incorporate that in my surgical lexicon. And then I came back and did an outpatient hysteroscopy session. So there were people who were awake, and we were talking them through an operation, which sometimes can be painful. So you have to have the skill to be able to talk to somebody as well as do a procedure at the same time. And all of those are really interesting and very involving. If I was also an obstetrician, which 75% of people who do ONG do both, I would also be delivering babies in all of that, and doing a miscarriage and a curette and a suction, and all of a sudden doing reproductive biology, and also doing some ultrasound. So it's incredibly varied what you can do within the course of the profession, and that's actually why I like it. I don't do the obstetric bit, but the gynae bit is excellent. It's fascinating, and you probably don't hear a lot about it, and that's actually because it's women's health, unfortunately. And this year, finally, they've given us some money to do endometriosis research, and the government's on board, and the reason for that is because the politician has endometriosis, and the yellow wiggle has endometriosis. But apart from that, it gets covered. So it is a not very well known as an extremely complicated surgical profession, and that's actually the reason I really like it. So my first clinic when I was a training medical person was at a colposcopy. And turned up, and it was the first time I'd actually done a clinic where you could see exactly what was going on. You were up close, up personal, you were very close to the screen, the patient was there, they were being talked through their procedure. And I thought, I really like this. There's someone talking to a person, a patient, at the same time they're doing an operation, and it's difficult, and it involves skill, but you can see everything. Apart from holding a leg in orthopedics, which I've done for quite a bit of time, and that's really where you're a long way away and you have no real connection to anything, and so it was a complete change, and that, not obstetrics, took me down that path. I mean, I went to this medical school as well, and I did well in ONG at the school, so that tends to make you feel sort of positively disposed to it, but it was mostly because of that. And now the laparoscopic surgery stuff is, I actually, given that you're a surgical society, I like the careful precision of it. You start something, you get in the zone, and have you heard of the term flow? Flow is when you don't think about anything else except what you're doing. And that's what laparoscopic surgery does. You start doing it, and you look up and you think, oh, 3 hours. And then you look back down again, and they say, we have to move the patient, it's been 4.5 hours. You go, 4.5? There you go. So it's something you get completely involved in, and it's complicated. So if you wanted to do something like that is involving and complicated, it's a very good profession, but at the same time you get to use a lot of communication skills, which I think, allows you to use the other half of your brain. So that's the reason I like it. At the end of the operation, you take out all your little ports and you put one little stitch in 4 ports, and the patient goes home that day or the following day. So that's one of the main reasons I think that ONG is a fascinating one. You've got all these sides to it. So, what are the pros and cons of the specialty? As I said, medical, surgical, radiological. So ultrasound is a very strong profession, and they're excellent ultrasound specialists. Endocrine, oncological, you can choose a mix of all. You can choose to use psychology and be very sensitive, or you can ignore the patient completely and be a complete proceduralist. So in all of that, it probably caters for a lot of people. And they're all well. So it's a mini world. You're not, the complexity of general medicine is not generally there, except if you do maternal fetal medicine, and then there's a place for you there because it's quite a complex world. So it's a small world that you can choose to leap into and decide whether you like to belong there. And from a surgical point of view, it's very satisfying because they're generally well patients with a problem from which they're likely to recover. So they come and see you, and afterwards you're generally, you can say, well, thank you for coming, we've now fixed this, off you go. And then they'll go and you'll get a little letter saying, I had my baby last week and it was great. And you feel like you've done something and they've changed their lives to a degree. Also, you see people with chronic pain, which is exactly the opposite. So you have this nice mix of people that you'll spend a lot of time with, and also a lot of people who have one problem that you solve. It's very collegial. I collaborate strongly with a neurologist and a colorectal surgeon simply because endometriosis tends to be all over the place. So you tend to have to get people in to take the other bits out that you don't generally deal with. If you like money, in obstetrics you can earn quite a lot of it. I don't do obstetrics and I'm happy, but it is something that if you felt like money was a big driver for you, obstetrics is one of the larger money producing fields. The problems, well, I'm late. Now, an obstetrician, they can't even say, I'm going to be here at 6:30. They go, well, I'll have to get someone on call for me. So you tend to be, it's difficult to schedule your life. And I think that's something that if you're a person who doesn't like that, I think you'd find that an imposition on your life. It's very competitive to get into. There's probably a bit of market saturation at the moment, but that changes all the time. So when I got in, it was just in the middle of the crisis where the government said they wouldn't necessarily cover your medical insurance, so people were getting out in droves. But now there's a cap, so you can't be sued for your life and your house and your family's income now because it's capped. So it means that it's much more security of income, so things have then suddenly become much more attractive. So as high profiles other surgical specialties suits me. And you do have to cope with some difficult things. Now, if you've delivered a baby and that baby's got a cerebral palsy or some sort of injury due to the birth process and they have to live out your life, sometimes that's quite tricky to cope with. Also, patients who come in, they generally expect a good outcome. You've come in, I'm going to have a baby. So when you get a bad outcome, that can really be difficult for everyone concerned. And also you have to act really quickly, and that can be quite stressful. I mean, you can be sitting down eating your tea and all of a sudden you're rushed off and you're doing some sort of operative delivery. So that can be quite a sort of a stressful thing. So I don't do any of that. My life is quite orderly and I like that. But in obstetrics it's not particularly orderly. And you're often having to do things simultaneously. So it depends what you want to do and what highly special you want to be in. Scheduling. So often I'm in rooms with an obstetrician and you hear the secretaries going, yeah, look, she's just gone. No, yep, probably 2 hours. So that's a person having to reschedule everybody on the rest of the list because they don't know when the obstetrician's coming back. Getting the operating experience now, because of the way things go, operative stuff is reducing because we have a lot of other interventions that are not so operative. So if you're a very surgical person, now, in order to get the operative experience, you have to do a fellowship. So I did a fellowship, a 2-year laparoscopic training fellowship. And really, you have to do that now, I think, to get a lot of operative experience. It's very hard to get into that now because it's so competitive. So getting the operating experience is probably the major sort of hurdle, I guess, to becoming a gynaecologist, mostly operative gynaecologist. Having been in 2 places at once, I reckon is a bit of a challenge, but it is very common in obstetrics. That one, and that one. Doing something really quickly. To have the presence of mind to be able to suddenly turn left and suddenly be doing something else in a very short period of time, I think that's difficult. And that one. So, when I was training, I had a consultant who had 2 nannies. And I said, why do you have 2 nannies? She said, well, I have one during the day and then I have one at night. Because if I'm called out at night and her husband was a surgical specialist, and he's called out, there's babies without anyone looking after them. So if you've got 2 people who are on call and properly on call and have to suddenly leave immediately, then yeah, maybe 2 nannies. Or you might have to have a very strong arrangement from the childcare point of view. But most of the obstetricians I know get around that okay. It's sorted out, but it is something to take into account because it is not just a surgical specialty where you can schedule stuff. If you do obstetrics, you really have to take that into account. So how do you get on the specialty? You do the medical degree, then the internship. I did 1 year of general internship, then a second year of residency, and then I started the program. And then I did 4 years of training, and then I got on the fellowship to do that laparoscopic training and do 2 years. That's now uncommon. You don't generally do that. Generally, you'll do 4 years and then a bit longer, and then get a laparoscopic fellowship. So you might be sort of, doing 8 years, sort of in the end. But that's not bad because you're training all the time, and it doesn't really matter as long as you're working. And I think most of you will have to accept that if you get onto training programs, you might have to wait a little bit of time. So that's not, I don't think, unusual. You fill out RANSCOG is how you apply. There's a college interview, and those accepted by a hospital are on the program. So you generally get matched, and you get ranked. So you have your interview, and you're ranked from 1 to 7,427, and then the person at the top gets to choose their hospital, and I think it goes on from there. There's no entrance exam, but there is an exit exam, and it's a written and an oral. Most people pass the written and the oral the first time, or occasionally the second time, and not many people get kicked off because they don't pass it. So like I said, there is the 4 years of the integrated training program, and then you do something else mostly. And I think that's probably going to be a strong thing. At the moment, 75% of us are generalists, and the rest have some sort of, subspecialty where they don't do obstetrics. But over time, I think that'll probably shift because it's harder and harder to know a lot about a small amount of things. And so to have to know a lot about a lot of things, I reckon will probably end up being a bit more subspecialised over time. But you can always be a generalist. There's a lot of them. Yeah. Well, when you do your own R&D rotation, I always have medical students sitting with me and see if your doctor needs help with a research project, and then volunteer to help with a research project. The last 2 years, I think I've got 4 medical students who are interested in helping with their research projects, and that holds you in great stead because anybody who wants you on a program wants you to demonstrate some ability to do research. And make sure the doctor you shadow is aware you want to do R&D and ask for any opportunities to extend yourself, and that most people give you a go because we're interested. That's what we want. We want people who are interested. In order to give yourself the breadth of stuff in the area, do a bit of urology or colorectal. Do a neonatal rotation and say, look, I wanted to extend myself. I'm interested in your area, so I thought I'd do stuff around it, again, to prove that I'm interested. And we all love people with the statistics, so do a great thing. It's not sounding good, but it's so helpful. I just employed someone with a grad dip, and I'm really happy. Okay, so we move to ectopic pregnancy. Okay, so this comes in. You see a person on a trolley wandering in. A young woman walks in the emergency department, collapses as she walks through the dental. So, what are your thoughts here? Given I'm giving the question, the lecture is probably fairly clear, but it's a fairly reasonable thing. Someone walks in and they can't give a history. They've collapsed, and that's actually half the problem. What do you want to know? It's a big deal, isn't it? They're collapsed. You can't ask any questions. It's like veterinary medicine. Oh, and I don't have anyone with me. And now what? So, what do you need to know? In general, we say every woman in the reproductive age group is pregnant until proven otherwise. So, she's in the reproductive. She's collapsed. She looks pretty well otherwise. We're going to assume she's pregnant. And if she can't give a history, then she's pregnant with an ectopic until proven otherwise. So, you have to assume that. You might say to yourself, okay, let's look at all the other differential diagnoses of collapse, and you go through, severe blood loss, cardiogenic sepsis, anaphylactic, all those other ones. But in general, your first choice would probably be an ectopic. So how would you, she's not there, she's not with you. How are you going to prove that? Well, yeah, but you could clear good bloods. You could overcome, yeah. So you're probably going to do the resuscitation at the same time as looking for the cause, right? So you'll probably put 2 wide bore catheters in, droops in. You'll take bloods for an FBE and a group and hold or a cross match. You'll do a beta HCG. Will that come back immediately? No. So even if you do an urgent one, it doesn't come back immediately. So you would probably put in a catheter and take out a bit of urine. And that bit of urine, then you test for beta HCG, and if it's positive, you think, oh well, I think I know what that is, and it'd be an ectopic. And you probably put an ECG and do all these other things. But when they say, oh no, she's pregnant, what happens next?
You do a fast scan.
You could do, yeah. And if there's someone in the department who could do a scan, you get them to come down quickly and do a scan and see if there's free blood in the pelvis. And if there was free blood in the pelvis, you wouldn't hang around. You just take it to theatre. Simple as that. Because you've doing a couple of steps, you've proven your problem, and you're going to do something about it. Yeah. Now there is a new test that's around that you can take a pinprick and do a beta excision on that. We don't have it. The Alston has it. I thought, what the hell? We don't have it. So hopefully we'll be able to get it soon, and we'll be very useful. So this is the other one. So that's an easy one, really. You just do two things and you take them straight to theatre. This is the young woman who's 26. She walks into the emergency department. She sits in the waiting room for a long time. She's completely normal, apart from the fact that she's 6 weeks pregnant. She's been spotty. And she's got a dull left iliac fossa pain, which is helpful as opposed to right iliac fossa pain when you think, So, how would you tease out whether she's got an ectopic? What would make you think, this might be a person with ectopic? And we're going to start with risk factors. So, what would make you think this person is more likely to have an ectopic than someone having some other pregnancy issue? Anybody ideas? Yeah. What in particular are you looking for?
Anything with the tubes.
Yeah, so something that could create adhesions, really, isn't it? So because an ectopic is a tube not working very well. So what do you think would be likely to cause adhesions?
Endometriosis.
Yeah, it can. Yeah, it's not the commonest, but it can. Yeah. Anything else?
Pelvic inflammatory.
That would be the commonest. So if you got pelvic inflammatory, so if you get chlamydia, a third of people who get chlamydia will get PID, and a third of the people who get PID will have salpingeal adhesions. So 10% of people who get chlamydia will end up with the adhesions. Okay, so that would be probably the commonest risk factor. Any other risk factor anyone knows?
Previous ectopic.
Yeah, that's a very good one. That's true. It's shown that there's at least one tube that doesn't work. Yeah, even if you've taken it out, you're more likely to have it on the other side because your risk factor is probably PID, which we've got both tubes. Yeah, so you're right. Previous ectopic. Anything else?
An IUD?
Yeah, and the reason for that?
Because you can't implant.
That's right. So it doesn't actually increase your risk of ectopic. It's just if you're pregnant, it's not likely to implant in the uterus. So that's exactly right. Does that make sense? Yeah. So any other thing that would make you think that she's got a ectopic? All right. So progesterone-only contraception and IVF. IVF is more likely to give an ectopic than a general. So it's usually 6 to 8 weeks of gestation. Why is that? Do you think? Pretty understandable.
Size.
That's right. So that's the bit where it gets big enough and it'll start to put pressure on the tube. So it gets too big and then it'll have ruptured already. So that's about it makes sense. So what a differential diagnosis. She's coming with this iliac fossa pain. So what could it be? It could be a normal ongoing pregnancy, couldn't it? Because she could just have come in with an all and she's got a cyst accident or something else happening, or urinary tract infection, or if it's on the right side of the appendix. She could have a miscarriage. So it could be normal ongoing pregnancy, it could be a miscarriage, or it could be an ectopic. So that's tricky. You did your pregnancy test, it is positive because you never know that anyway. So how are you going to sort out whether it's a miscarriage, any of those things, do you think? Ultrasound? Yep. And what would you expect to find on ultrasound? What if you're 4 weeks pregnant? Are you going to see anything on ultrasound? Commonly not. Pardon? Yeah, look, again, physiological stuff in the pelvis can often a bit of fluids there, so it's not a particularly good discriminator. So, yeah, go on.
Beta-HCG.
Yeah. It's the levels that you care about, because by the time the pregnancy does exactly the same thing at the same time, pretty much. So by the time you get to a certain beta HCG, you should be able to see a pregnancy if it's an ongoing pregnancy. So if it got if the pregnancy got into the uterus, then at 1500 to 2000 beta HCG with a transvaginal scan, you should be able to see a pregnancy in the uterus. And if you can't see a pregnancy in the uterus, it's an ectopic. If it's less than that, you're a bit stuck though, aren't you? Because then you don't know whether it's in the uterus and it's doing that normal thing or it's not. So how would you sort that out, do you think?
Serial beta HCGs.
That's right, but what if it's an ectopic and you need to operate on her immediately? It's pretty much on clinical grounds really, but it's true. So you've got to work out, you examine her and you say, oh, well, she's got evidence of blood loss, she's pale, she's got generalised abdominal tenderness and she's got cervical motion tenderness, then you think, gee, maybe it is an ectopic and we do something about it. That collapse patient, that was easy. You just take it here. But these ones are more tricky. You have to sort of think your way through them. So this is you get the investigation. The ultrasound says there's nothing in the uterus to be an she's 1,000. She's positive blood group and her FBE is normal. These are the investigations you've got. So what is your plan in this circumstance? So she could have a complete non-pregnancy, couldn't she? Yep. She could have a miscarriage. Yep. She could have an ectopic. So what are you going to do next? Would you admit her? She's coming with a little bit of bleeding and left with laparoscopy. Does she get admitted?
Could you admit her for observation?
You could. I mean, it could be a normal pregnancy. It's pretty.
Would you ask her to come back in 48 hours if you thought she could make it back?
That's much more likely. If she's well and nothing much is happening to her except for that, and this is what you found, you generally get her to come back in 48 hours. What would you expect in 48 hours?
Yeah, so you'd stay the same rise or fall.
Yeah. So what's it supposed to do in a normal pregnancy? What sort of percentage rise? So if you saw 1,000, what would you expect if you got back in 48 hours?
200.
Yeah, at least 66% up. So you think it would be 1,600. So at that stage you should be able to do a scan and then be able to make a decision, shouldn't you? But otherwise you're sort of saying, okay, what if she came back and it was still 1,000? What do you know?
It's probably
No, you don't know that yet. No. You know that's probably not a normal pregnancy. And that's a plus, because then everything you do after that is you're not damaging something that could be an ongoing pregnancy. So if you come back and it's still 1,000, you say to yourself, okay, well, it's likely that it's not an ongoing pregnancy. I'm not worried about me trying to preserve this beautiful human being that's about to come out. I now can, think that it's not likely to happen. So, diagnostic assistance. If you do 1,000 and you're if you've got to do 1,000 and you're in a specialist centre like the Mercy, you should probably see an ectopic. It's really in the community that we say 1,500 to 2,000. They can say they see them at 800. So it's more just you can't rule them out or in. But if they say, look, there's nothing in the uterus and there's this mass in the left iliac fossa in what looks like a tube, okay, well, it's likely it's an ectopic. But if it's in the community, it's a bit harder. And if it's a transabdominal, it's much harder because it's much further away from where your uterus is, so you're much less likely to be able to see as well. So you want to know how the ultrasound was done, and you want to know if they had any previous scan to compare to, because if she had one 2 days ago and had a little pregnancy and now doesn't have it anymore, well, she's had a miscarriage and it's coming down. Does that make sense? Yeah. So, and you want to know, is it appropriate to dates? So she says she's 6 weeks pregnant. 1,000 is not appropriate for 6 weeks pregnant. It should be much higher than that. So we're saying to ourselves, okay, well, if her dates are pretty solid, it's likely to not be an ongoing viable pregnancy wherever it is. Have they got their dates wrong? And that can be often a problem. You might have a bit of spotting, think it's a period and it's not. So you must be, so all these things you have to try and tease out. So it could still be, as I said, a viable pregnancy, a miscarriage complete, blooded ovum, or an ectopic pregnancy. How do you sort it out? Well, like I said, it's easy if she's collapsed. You get straight to theatre. Then your only decision is whether to do a laparoscopy or laparoscopy. And I try to do a laparoscopy in all situations, but what's the problem with the laparoscopy? Time's one of them, whoever's the time, yes, but it's actually physiological changes that happen when you do a laparoscopy. So you will increase the intra-abdominal pressure with gas, and sometimes that can reduce venous return and they can get an even worse collapse. So sometimes you'll go, she's pretty bad, I'm actually going to do a laparotomy because I don't want to increase her physiological changes. So that's a decision you might make on the day. But mostly we would try and just do it laparoscopically because you could be wrong. Actually wrong, and she's had a ruptured AAA or something, but not common. If there's no evidence, if not, and there's evidence of rupture, so she's not collapsed, but she's got a rupture. So how do I know that? I scan pretty much. They say, what you talk about free fluid, there's a lot of free fluid. Then you're going to say probably, okay, well I'm going to take it at the end and do that. If not, then you've got to work out whether to admit or not, like I said. And that's often a tricky thing. You'll often be sending people away, but ectopics can rupture at any stage, so you're always a little bit anxious that you might have them come back. So that's a tricky one whether to admit them or not. And then you, exactly as you said, follow with a bigger HCG, and if you can, do a scan when they're 1,500 and above. My second topic is the point is the annoying one. 21% of ectopics will appropriately rise with their BOCG. So you might sort of go, oh, come on. It's doing exactly what it's supposed to be. But in general, that's why you have to have a fairly high index of suspicion in general. You have to say, well, pregnancy can do the right thing and be a normal pregnancy. You can do the right thing and be an abnormal pregnancy. So if someone has ongoing pain, you would do serial BOCGs and see what's happening. If it's falling, as I said, it's likely not viable, and it's plateauing, it's likely not viable. But both of those situations, you don't know where it is. Yeah.
With the 21%, how long will it just keep rising normally?
It tends not to. It tends to just, because the pregnancy has to grow, and if it's in a tube, it's a normal pregnancy. It's just in a bad place. So it can't, it should, BOCG should, appropriately double, and then all of a sudden its blood supply is not well managed, and away it goes. Yeah. So, ectopic pregnancy is 1% of pregnancies. Increasing in NIVF, it's doubled, it's about 2% of pregnancies. So, apart from that, most of them have abdominal pain, most of them have amenorrhea, and some can even pass tissue. But if you say, I think I've had a miscarriage, I've passed tissue, that doesn't still mean that you've had a miscarriage, because it could just be a decidual cast. The decidua from the lining of the uterus could have just passed. So it doesn't really mean that you've had a miscarriage. It means that you've had some sort of pregnancy. Most of them are tubal, but they can be anywhere. If you see that little diagram there, you can be in the fallopian tube, it can be on the ovary, it can be in the abdomen, it can be on the cervix, and now, which is not there because it's newer, we now have caesarean section scar ectopics. So a caesarean section, as you can imagine, is not as well nourished as the rest of the uterus. It's a scar. So if you implant directly on the scar, you're not putting yourself in the endometrium, you're actually putting yourself on poor tissue that doesn't have very good blood supply. So you can see that then it's actually an ectopic pregnancy. It's just in the scar. So that's much more difficult to manage than all of the other ones, but it is another series of problems we're creating by doing lots of caesarean section. So how do you treat it? Well, you can wait. I mean, I've watched ectopic pregnancy and they can resolve. If you feel like that it's plateaued and it's actually fallen by the time you've seen them and you've worked out what's going on, then you may just not know where it is. So you may just choose to watch it. And you don't know if it's a miscarriage or an ectopic, but you can't see it. They're well, so you might just follow it until the BOC drops. That's probably the least common. Or you can do something medical, or you can do something surgical. So methotrexate is the commonest thing we would give. So it actively attacks growing cells. So that's a very good source of growing cells. And so we would give them methotrexate depending on their body mass. So it's a BMI-based regime. And then we watch what happens to the BOCG. Paradoxically, it might rise for the first couple of days and then fall. So we have to hold our nerve enough to wait for the rise and then wait for the fall. And then as long as there's a 15% reduction, then we think it's working and we may then give a second dose. Contraindication to medical therapy. When wouldn't we give the medical therapy? So nowadays, mostly we will give medical therapy unless these things are present. So if someone comes in with ectopic, we're more likely to medically than surgically manage them. And so if their BOCG levels are high, or there's a tubal mass that's greater than 33.5, these will vary from hospital to hospital. They all have their own protocols, but that's a sort of a standard-ish protocol. And if there's a fetal heartbeat, that's less likely for it to be resolved on its own. And basically, someone has to come back and come back and come back. And if you think they really won't comply, then maybe they're not the right person for medical treatment either. So you may say, on all other grounds, they seem to be good, but lots of people are going on holiday and they say, I just want this resolved before I go on holiday. Otherwise, it can take them a month to resolve it. Now, you've not planned on this pregnancy, it's happened, and all of a sudden you've got a month where you're having to see a doctor. So you might choose not to do a medical therapy for that reason. Hypersensitivity, renal disease, or breastfeeding, we would stop. Surgical management, we generally try and do a self-injectomy unless there's a reason. Why do you reckon? Is there a good reason why you take out a tube, do you think?
It's implanted once, it will implant again.
Yeah, so it's actually proven that it's a damaged tube, really, isn't it? Yeah. So it's likely that it's got an increased risk of having another ectopic. That's exactly right. It's not that it's going to, but it's an increased risk. So we would take it generally as long as the other side looks okay, because you're better off having 2 damaged tubes than 1 damaged tube. Okay, so we look at them, and if both of them looks terrible, Then we open it up and do a salpingostomy usually, take the ectopic out and leave both damaged tubes. And then we'd have to say that they have quite a high risk of having another ectopic. And the risk would be somewhere between 10 and 30%. I thought I'd show you a salpingectomy. So this is what you see. Now you can understand that that's, can you see that? No, that looks a bit difficult. So do you want to turn some lights out?
You can try.
Really good, right? That's looking better. Okay, so that's what you'd expect. You'd expect that sort of free fluid. So if you did a scan, you'd actually be able to see that free fluid in the pelvis. And that's quite a lot of free fluid, really. How much do you reckon in terms of mils that would be? It's a laparoscopic view. No, it might be 100 mils, 200 mils, something like that. So you can see some free fluid. And can you see that tube? It's got a big bulbous end. So if it's bled outside, it's probably first bled into the tube. So the tube looks a lot bigger, and then the blood's run out. It hasn't ruptured. It's just bled. So hopefully we can start. So what have you noticed that? Oh, you probably don't notice because you don't know what we usually do. In laparoscopy, we usually lift the uterus up. Now we haven't lifted the uterus up, have we? The reason being because I don't know if there's something in that uterus. What is a possibility? A heterotopic pregnancy. So you could potentially have something in the tube, and so twins. One's not made it out the tube, and the other one's in the uterus. So we tend to try not to instrument the uterus to hold it up out of the way to make this an easier operation, until we're pretty happy that it's an ectopic one. And then if we have an ectopic, sometimes we won't anyway because we're a bit worried about a heterotopic pregnancy. What do you reckon is the heterotopic pregnancy rate? It's very uncommon, 1 in 50,000. So mostly you're not going to do it. But with IVF, it's more likely, that sort of thing, because you've got, yeah. So this is what I'm showing you is, look how much, there's a reasonable amount of blood in there, and it's often coagulated, so it's gone into a clot thing, but it's actually quite stable, isn't it? It's not actually really bleeding a lot from there. So that might be what happened. Once when she had the pain, she came in with the pain. It bled a little bit, and then it's now settled. And then you can quite clearly see the ectopic pregnancy in that tube over there. You compare it to the other tube there. You can see that looks a normal tube versus an ectopic pregnancy. We're going to do a self-injectomy. So what we have to do, what's important about a self-injectomy, do you think? Anyone got any ideas? Self-injectomy is when you take the whole tube.
And trigger like rupture unless the blood supply around the area.
Yeah, you can actually cause a great big bleed, yeah, before you've got the blood supply sorted. But there's two things you want to make sure you don't do, and one is to cut the blood supply to the ovary, because the ovary can be quite close to the end of the tube, the blood supply, so you don't really want to get that blood supply. So you only want to see there's a blood supply in the ovary, right there. That's the blood supply in the ovary, and that's the tube there. So if I did that, which I'm looking like I'm about to do, then you can actually get the ovary, the blood supply in the ovary. And that's not a good thing, is it? So if it's a lot of bleeding around, you can imagine that might be a bit of a problem, that you might actually be trying to stop bleeding and then you stop the blood supply in the ovary, so be careful. So there's the ovary over there, and there's the tube that we're now quietly taking down the mesentery of the tube. And it's a sequential operation where you first coagulate it and then you cut it. And the blood supply there is quite good, so I try not to go beyond my blood supply. And where's the end of the tube? So you could think, well, that's the ectopic. Let's take that out now. We've done the ectopic. You can see the end of it. Why don't we take it out now? Why don't we continue to take the rest of the tube? Well, there's a risk of another ectopic, isn't it? I mean, if I don't take that whole tube, that's a pretty damaged tube. I don't know where the damage is. So if I leave the rest of that tube in, even though it hasn't got the ectopic in it, if I stopped it there, then I might leave that damaged tube. This is the registrar doing it, but it might leave a damaged tube. So we would tend to make sure that we take the whole tube right down to the cornea. So that's what we're doing now. We're going all the way along the mesentery, and then we get to the cornea there. You can see the cornea, and we take the cornea. And it's a sequence of events. Now then we have to say, okay, well once we've taken it all out, how would we get it out of the pelvis?
Will it not squeeze through a tube?
Not well, sometimes. Yeah, sometimes it's a sort of 50-50 proposition.
Do you cut it out?
Well, I don't really want to because then I've spread all this tissue around the pelvis. So you could. And I don't think I showed how to get this one out, but there you go. So that's, you can see the whole thing is you've taken all the tube all the way into the uterus, and there it is sitting there. And so now we've got to get it out of the pelvis. There we go. See that? That's the whole tube with the ectopic pregnancy in it. And so now we have to get it out. So we put it in a bag, and then we take the bag out of the and I don't think we had a close look at the other tube, but the other tube looked normal. So that's the first thing in the operation is we don't put something in the uterus, and we look at both tubes. If it looks like it's a ruptured ectopic, then we say, okay, it's very unlikely to be heterotopic pregnancy. I can put something in the uterus to move it around. And then the other tube looks normal. Okay, we're doing a self-injecting, not a self-investing. So when you do that, and sometimes you'll go in and you'll say, you know what, that's not on the tube. It's on the ovary, or it's a corneal ectopic, so it's actually in the horn of the outside of the uterus. So it's not implanted in the middle of the uterus, it's almost out of the edge. So then we can do a corneoectomy or something like that. Not happen very often. So what's the follow-up? You've taken this out, and you have to make sure their beta-HCG falls back to normal, because if you did a methotrexate, it would be very slow. But usually once you've taken out the tube, you've got rid of the pregnancy tissues, the beta-HCG will turn to normal quite quickly, and she has to wait for that before she can try and get pregnant again. 10% recurrence rate, we think. And the other tube, as I said, can be damaged. And so what would we say for the next pregnancy is, right, we already know you've got a damaged tube on one side, which we've taken out. The other side may also be damaged, so we need to do an early scan to make sure that it's actually gone into the uterus. You know, your pregnancy's made it into the uterus. So we do about a 5 to 6 week scan and say, yeah, it's in the uterus. And and that's about it. Okay. So has anyone got any questions about that? Has anyone got any general questions?
You spoke about research being pretty important to get into specialty. I was just wondering if doing research in another area would still convey some advantage, or whether it really has to be.
No, I think it would convey some advantage. Yeah. I mean, what we want to do is see that you're interested in it and that you've got that sort of methodology as your background. It shows interest as well in OG if you do it in OG, but sometimes that's almost impossible. It's not as easy to organise, but it would show some interest in the area. I think if you look on the website, there are sort of, for Laparoscopic, there are points that you get for various things that you do. So if you look them up, you can work out what would be good points to get you onto the program. Anything else?
If the beta-HCG wasn't falling in that instant after you had already done the self-injectomy, would you have to go in and do another diagnostic?
What do you think would be the situation? So I've done a lab. I've taken out a pregnancy, and the beta-HCG is not falling.
Second.
Another pregnancy. Yeah, isn't it? Very uncommonly, it can be, another pregnancy. As I said, it's 1 in 50,000 is a heterotopic pregnancy, but I guess that's what we'd worry. It was a heterotopic pregnancy, and occasionally it can be a cancer. Occasionally it can be other things that will cause a beta-HCG to remain. My biggest memory is a woman who came in and said, "I'm going to die," and I'd say, No, you be ectopic pregnancy. We'll do this operation, you'll be fine. And she did die because she actually had bowel cancer. And the beta-HCG was a strange kind of bowel cancer that was in her system. So it's awful when patients say that sort of thing to you, because I thought, man, no, this is easy, we know what it is. So occasionally it can be something else.
In terms of training for OG, is it very balanced between obstetrics and gynae?
No. Obstetric is a hungry beast.
Okay.
So if you were to do obstetrics, it takes up 94% of your time, and then gynae takes what it can get. But that's why I think you need to do a laparoscopic fellowship, because in fact, otherwise you don't get the surgical exposure. Obstetrics is all-consuming, honestly. Yeah. Every hospital is just getting more and more babies coming through, and so you've got 5,000 deliveries a year, 6,000, 7,000, we're capping.
Rotation as
Well, yes. You can do, You actually can do a non on the program. So your first year is you're a resident. You're not on any program, or you can be a first year as a on the program. So if you were say wanting to do general practice, you might want to do that 6 months of the DIPOLS in order to get you more skills to be a GP. So you would apply as to be a resident, and then halfway through you might think, gee, I really like this, and then apply to be on the program. Yeah.
What would you suggest for someone who's not interested in the obstetric side,
That was
the
me.
women's health, but isn't so interested in being a surgeon?
Totally, there is so many parts of the profession that you can do that. I have a very good friend who's an ultrasound specialist. That's all she does, and so she did O&G, and so you have to do all those 4 years, and then she did 2 years of ultrasound training and went that way. You can be a IVF doctor, so they're not as surgical. They're procedural, but they're not as surgical. You can also be, this can be, probably not gone. The rest of them, you can just be a general obstetrician and not do any gynae. You can, of course, you can do dermo-gynae, would you believe? There's a whole specialist of dermo-gynae, so you can spend all your time there. You can be an STD specialist and work in family planning and that sort of thing. So it's actually, you can do almost anything. As I said, it's a little mini world. You can probably find where you want to be.
Is there psychiatry?
Well, I would say you do a lot of psychiatry as part of O&G. Like that's a really big part of what you do on a day-to-day basis. And you do counselling, you do sexual counselling, like that would be, a fairly strong role if you want to go down that path. You could choose to do that. If you were a gynaecologist and you decided to see a lot of people with pain, then a lot of people would come in with dyspareunia, and then you have a lot of sexual counselling, which you could then go and do courses in. So you could actually incorporate that into your field.
Do they have like mission and healing time away from the program?
Yep. No, we were late on the bandwagon, unfortunately. Yeah. So, but job sharing then is really common. So you can have people job share in a myriad of ways. So you could do, someone does Monday, Tuesday, Wednesday, someone does Thursday, Friday. You could do week on, week off. You just have to find someone who wants to pair with you, and then you work out the way that you would organise your job share. So that's now just accepted standard practice. Yep. Yep.
What's the role of the diploma? Is that
Diploma is more if you want to do GP. So you do a diploma, or say you want to do it to be in an emergency department somewhere. You could do a diploma and then work in an emergency department. And it might be a way of you working out whether you liked it. And so you could go, yeah, I do, and then apply for the program. Yeah. So is anyone interested in O&G? Oh, okay. It's a good job. I really like it. But as I said, I only do the gynae bit. But the people who do obstetrics say it's addictive. It is. Because people come in and you save the day. You come in, there's something wrong when you save the day and you produce this child and everyone thinks you're the best thing ever. So it's actually quite it's a good role for, personal heroism. Yeah, but yeah, so it depends on how you feel about things. But it does require you to be, I think, able to cope and change direction. And not everyone likes that. Okay.
Oh, one more question?
Yeah.
I was just wondering, throughout your time as a gynaecology, if you found a lot of opportunities to advocate for women's health and things like that.
Yeah. Well, how do you put this? I'm at a Catholic hospital. So some of the first things were to work out how you feel about terminations. There's a lot of ethical issues in O&G, more than any other profession. So then, how do you feel about abortion? How do you feel about that? How are you going to advocate that? So we did some marches and rallies because of that, which is very difficult because you're in a Catholic hospital. So you have this quite strange situation where you go to work where you have one ethic and you go to something. So there's a bit of that. I go to Mongolia every year and we do a lot of women's health stuff there. I'm on a committee for endometriosis for the government, making guidelines and sort of health interventions for early detection of endometriosis, which is now hopefully going to be rolled out. We've got some money for. it's sort of, it depends how much the community is interested, but you can be an individual citizen doing it as well. So yes, you do have roles of advocacy, and if you sort it out, you find it. But unfortunately, a lot of this stuff, not very many people are interested in. It's tricky. Did you want to be the person that has eggs thrown at your house and car and do terminations? Really? That's a big deal. So few people do that. I lived in a street when I was growing up where there was a gynaecologist who did terminations and regular egging. And bad things written on the walls. I don't know how they worked out that they did them, but little messages written on their heads. It's like, really? But people feel incredibly strongly about that. That's one of the things that people feel really strongly about. So you can find yourself in a situation where your ethics don't align with the person that you're teaching a lot. So when you say advocacy, it depends what you think about that. How you feel about it.
So last question. Sorry.
Yeah.
I know ONGs and employers are having like the highest rate of lawsuits or legal trouble. Is it like insurance wise?
It's okay. I mean, most of us would pay, it depends. An obstetrician would they've saved some $30,000 in insurance a year, something like that. Yep. They used to pay $100,000 because it got to a point where you found it very hard, there was no cap. So you could be sued for $6 million. If you had produced a baby that needed care for the rest of their lives, you could be sued for like an unmatched amount of money. Now it's capped, and there's now chests for disability, so it's much better. So you just pay the money, and you just have to accept the fact that someone's going to sue you. Yeah, at some point. You just have to accept it. No, it's great.